As Joel mentioned, there's a lot of things that go into pain management that we're all aware, because how many of us have ever been in pain? Anyone that doesn't raise their hand, you're lying. How many of us have taken care of patients that are in pain? Sometimes that can be a real challenge, can't it? Especially if they already come in and they've already either got preconceptions or they have chronic pain, and then we're going to give them acute pain on top of it. How many of us have taken care of surgical post-op patients? And you've got to worry about drains, and you've got to worry about dressings, and wet to dry changes, and are they able to get up and go to the bathroom okay? But also, there's probably going to be some pain associated with wherever that scar is, whether it's a laparoscopic surgery, a general surgery, an X-lab, something. I mean, there's so many different things that go into it. So what I want to focus on this morning is, what are those questions that you're either going to get from either if you are a nursing instructor or a nurse yourself, you have students, you're probably going to get questions from them, and those students that are here, you probably have at least one or two questions you've seen from the books. But I guarantee that every single patient that you're going to touch over the course of your career is going to have questions. So I want to make sure that I can at least give you a couple of things that might be useful for your ability to take care of patients, and then relate to them what the safety and efficacious types of concerns are related to pain management. How many of you remember Mythbusters? I'm probably dating myself at this point. I think it's like Mike Rabbit Project or some other iteration and such. But basically it looked at what is myth, what is fact. So we're really trying to make sure we have a good understanding as to, is the patient or the provider asking a question based on preconceptions or based on information and knowledge? So what I want to do this morning is I want to briefly touch on a couple of the different medication classes that are available for pain management. And I also want to look at a couple different scenarios that some patients run into over the course of their pain management. How many of us are familiar with pain scales? So many different pain scales. I mean, there's between numbers and faces and Wong-Baker. There are different scales for different patients, because not everybody fits into the same mold. If you have a patient with advanced dementia, can you use a 0 to 10 scale? Probably not. What if you have a child that's under the age of 2? Again, you're probably not going to be able to use that scale. So it's important for us to recognize whatever scale we're going to use, it needs to be based on the right patient. So if you have that patient with advanced dementia, we need to use some kind of non-verbal types of communication scale so that we can gauge their pain. That's number one. Number two, if we start at pre-admission or at surgery or post-operatively, whatever scale we started to use, we need to use that same scale. Well, why would we need to use the same scale? I mean, are the scales that different? Actually, they are. And the documentation is also different. Now, I'm not going to say you have to learn every single part about either pain AD or the Wong-Baker Faces scale, but what I want you to know is that the numbers do correspond to what the patient tells us. So because pain is a subjective measurement, it's something that we have to try to quantify, because all of us, we need data. Why do we need data? Because, as Joel mentioned, we have to document everything that we do. It's important. So being able to do that with assessment and have it be on the same scale, if you use the same scale to say, my pain is high or an 8 or whatever the number is, and then I do my medication or I do my non-pharmacologic therapy, well, afterwards I have to reassess. If I use a different scale, the numbers aren't going to match, and they don't matter at that point because I'm comparing apples and fireworks. All right, myth or fact, folks, this is where everybody in the audience gets to participate. Pain scales are only important once the patient is out of the post-operative anesthesia period. Yes or no? Looks like it's false, because not only in the PACU, but what happens when they hit the floor? What happens when they're getting ready to be discharged? These are times where we have to have documentation that we looked at the patient, we did an assessment, we appropriately got the information that we need to see, is their pain going up or down? What are the different things that we use in surgery and other modalities, especially when patients have pain? Many of us are familiar with opioids. As Joel mentioned already, there is an opioid crisis in this country. If you're not familiar with the opioid crisis, take a look at the news. This is the reason I stay away from reading the newspaper and basically every type of media for that matter, because it always seems like there's a story about either someone overdosed or someone had to use naloxone Now, from a pharmacist's perspective, because we have naloxone available in the state to anybody that wants to go to a pharmacy and obtain it, I think that's great from an education standpoint. But it's really just unfortunate from a base characteristic that we have to have naloxone available for everybody. And while I recognize that that is definitely just the way things are, we as healthcare professionals all need to be aware that our patients potentially may have kids at home, they may have grandkids, they may have animals, and anybody can get into a narcotic or a quote-unquote narcotic, which is also known as an opioid. Here's something that I have tried to relate to people in the past when I tell them. If I feel that they are not truly grasping the gravity of what hydrocodone-acetaminophen number 30 actually means, especially to a child, I say you need to treat it like $2,000 cash on a loaded gun. So in other words, it needs to stay in a safe. It needs to be locked up. It needs to be kept away from people. And it's not because that patient may aberrantly try to go in there and take their medications. But what happens if, for example, here's a good story. In Philadelphia, they don't actually allow people to go in and tour homes by themselves because a lot of people would actually go on those home tours. They go to the bathroom. Oh, look, this is their medication. No, that's my medication. So they actually disallow it because it happens so frequently. We have other things that we use other than opioids, though. Things like non-steroidals. How many of us are familiar with ibuprofen, naproxen, or one of my favorites, IV or IM ketorolac? That's got some really good qualities. It's great anti-inflammatory potential. Adjuvants. What are adjuvants? That's a long word just to say, basically, there are things that don't work on inflammation necessarily, but may work on other things like neuropathic types of pain. And we can always talk about those things later, but I really just want to focus on the fact that we have a lot of different categories of medications available for patients post-operatively. How can we give patients opioids? We can use them parenterally, which means that we can use them either intravenously or as a continuous infusion. I have up here to avoid intermuscular and subcutaneous for one reason. From a pharmacist standpoint, if you give a patient a medication like that, the absorption is going to be erratic, and how much the dose actually gets to the patient is going to be erratic. Do you want erratic or do you want consistent? For me, if I'm trying to record reassessments, I'm going to want to know something that's consistent. The good thing about parenteral is fast onset, but also fast offset. So if that patient is just in excruciating pain and they just had physical therapy or they just got out of post-operatively, you could give them a dose of parenteral opioid. That makes perfect sense. Now let's say that that patient does have return of bowel function and they're able to take sips and chips as they are done with their general surgery or whatever elective procedure that it was. We're probably going to get them started on immediate release preparations, things like hydrocodone with acetaminophen, oxycodone with acetaminophen. They even have morphine with no acetaminophen. We have a lot of different options available. Now, why are we going to use immediate release preparations? Well, two reasons. Number one, can everybody be walking around with an IV catheter forever and ever, amen? No, gets infected, things like that. We also have to DC them before we send them home. The other thing is when that patient gets home, we are going to have to work with them to make sure that these immediate release agents are able to manage their pain. Now notice, I will not use the term take care of or cure or heal. I will say that and I'm not even going to say that I want a pain score of 0. I want them to be functional. That is ultimately what we're going for, is can I increase my activities of daily living? Can I increase my functionality by using these medications? If the answer is no, then that's not a medication we should be using. So if the patient tells you that, just like Joel said, if they can pick up their grandkids, they can mow the yard, they can go back to work. Those are things they want to do. They will be motivated. If these medications help them to get to that point, then we are doing our job as healthcare professionals to get them to where they want to be. That's ultimately why they had the surgery in the first place, for the most part. Now, the immediate release preparations, they do take a little longer to work, between 15 and up to 60 minutes, but they last for between 3 and 4 hours, some of them even 6 hours. So recognizing that it's not a fast onset, it's also not a fast offset, but it will manage their pain not only while they're here, but also when they go home. And truthfully, it is an appropriate practice if we have someone that's receiving an IV or a parenterally administered opioid to make sure that when we give them that orally administered, that it works. We tell them that it's going to take longer, but we explain that it's going to last longer. And that's really an important patient counseling point. So let's talk a little bit about non-steroidals. Not every patient that has a surgery is going to be an appropriate candidate for non-steroidals. In a number of instances, you will have an appropriate candidate, especially post-operatively from ortho, from general surgery. There are a couple exceptions, but we can talk about those offline at some other point. In the same sense that you could use an intravenous, such as ketorolac, one of the strongest non-steroidals that we really have available to us in this country. But have you ever seen oral ketorolac used on the outside? Probably not, and I'll tell you why. So there's this thing in all drug literature called a black box. If you ever hear of a black box, I would pay attention. Rationale behind that is not only the federal government, but also the drug company have gotten together lawyers to lawyers and said, this is a problem. And if we go past this problem, whoever is using this may actually have a negative outcome. The negative outcome from this is if you're using ketorolac for greater than 5 days in a row, you increase the risk of GI hemorrhage and death. Death. Not just, oh, it's going to be a minor bleed, it's going to be in this. Now, I'm not trying to scare everybody, but I am saying that we should just be aware of these things. So a parenteral ketorolac for a few days and then transitioning to an oral non-steroidal, that's probably going to be your best bet. And again, if you've tried it the IV way or the IM way, with ketorolac you can use IM, that's okay. Not very often, but it is okay. Using those oral on a scheduled basis will give you steady, consistent anti-inflammatory activity. Again, leading to what? An increase in functionality. It's really important if you have patients and when you're talking to your patient about going home on ibuprofen or on naproxen or some other non-steroidal, make sure they take it with food. I can't tell you how many times I've seen on the chart, patients allergic to ibuprofen, patients allergic to naproxen, patients allergic to aspirin. And I go ask them, so what happened when you took this? Well, I got an upset stomach. Okay. Have you ever taken it with food maybe 20 to 30 minutes prior to your dose and then take a big glass of water with the dose? That might actually help with that. The reason the water's on there is because the way that non-steroidals work, not only are they good for anti-inflammatory activities, but they can be kind of damaging to the kidneys. So if you have a patient that has a renal dysfunction, acute renal insufficiencies, you want to be real careful about your dosing on ibuprofen and any other non-steroidal for that matter. Here's just a couple things we're going to talk about as well. And I really think that Joel already kind of hit on this, but acetaminophen by itself can be utilized for its pain management. It's not going to lower pain scores by 5 to 6 points every time, but it might lower it by 1 or 2, and sometimes that's enough. Now, one misconception that I do hear, that I didn't list up here, is that, well, my patient has liver dysfunction. Okay, so they could still use acetaminophen, but you have to keep in mind you have a lower threshold for a maximum dose. There are patients that have a child Q of A or a child Q of even a B. As long as your acetaminophen is not exceeding 2 grams in a day, you're generally going to not cause an increase in their liver dysfunction. Now, there are some people that just want to stay absolutely away from it because what if they're taking over the counters and what if they're taking other things, especially around cough and cold season, like flu seasons, Octobers, Novembers. What do people like to get over the counter? Cough and cold remedies. What do those have a lot in them for the most part? Acetaminophen. Make sure that they know that, so when you're discharging someone and they're on hydrocodone acetaminophen or oxycodone acetaminophen, we're into that cough and cold and flu season part. Make sure you just tell them that if they do go to the pharmacy, to let the pharmacist know there, or tell them to just be aware that the acetaminophen that they're getting might be cumulative. When talking about some of the agents that we use perioperatively and even post-operatively, local anesthetics come up a lot. The reason I left it here is because there are some patients you may have taken care of or may be familiar with, especially if they have diabetic polyneuropathy. They may already have a lidocaine patch on. Well, that's kind of interesting. Now, we do have one of our surgeons that uses lidocaine patches for that infusion of local anesthetic at the local site. One thing I will throw out, if you have a patient that's going to be on those patches, the patch needs to be applied for 12 hours and then removed for 12 hours. It's not a continuous thing. It's not like a fentanyl patent that stays in place for 2 to 3 days. 12 hours on, 12 hours off. I make that connection between that and nitroglycerin. Has anyone ever had taken care of a patient on nitroglycerin and then they're on a fixed dose, but then you have to keep increasing just to get their blood pressure under control? It's called tachyphylaxis. Basically means that your body is becoming, for lack of a better word, immune to the drug, and you have to increase it in order to get the same effect. So I mentioned that patients may actually have pain prior to coming into the hospital. If those patients come in and they're already on oxycodone 80 milligrams, ERQ 12 hours, plus Percocet 10 every 6 hours scheduled, plus duloxetine and this and that and the other, it's really important that when we're able to make them resuming ice chips and meds with sips or clears once they're post-operatively, we need to restart their home medications. Why? Because if we don't restart their home medications, we're going to be using the post-operative morphine 4 milligram pushes, and the patient's going to be screaming in pain once anesthesia wears off. If we get them back on their home dosing, that at least gets them to their baseline. Because they were probably a baseline of a 4 to a 5, maybe even an 8, whatever their number was, pre-operatively. So when we can resume their home medications for pain, we need to resume their home medications for pain. This will also let us use those post-operative medications, and keep in mind that if you have a patient that's already on, let's say, morphine, extended release 100 milligrams every 12 hours, 2 of IV morphine every 4 hours is not going to cut it. So that's that opportunity to talk with the surgeon, with the NP, the PA, and the rest of the care team about, are we managing our patient's pain appropriately? Now, as Joel mentioned, I also work in the emergency department. So I say, while I want it to be effective, the most important thing is I have to be safe. So if my patient's already drowsy and dizzy and they're not acting appropriately and they're already post-anesthesia for enough time, I don't want you to restart their home meds yet. We need to make sure that they can do that one important thing that's necessary for everybody in this room, breathing. Breathing is one of those things, and respiratory depression is a very real thing. And so I do want you to be aware of that, especially in your post-operative patients. So patients should be on an oral pain regimen of either an opioid or a non-opioid to facilitate returning back to activities of daily living, and we're going to not rely on a pain score of 0. Fact, fiction. I'm not going to judge you one way or the other. 50-50 shot. So they should be on an oral pain regimen before they go.
Opioid and non-opioid. Yeah. And then, I don't understand the last part, what you're saying. That it's okay
And
for
returning, and then trying to facilitate returning to their activities of daily living, and we're not just trying to treat them to a pain scale of 0.
I would agree with that.
Yeah, I would agree. You get a cookie or a gold star, I don't know, whatever you want, you can buy you coffee. So again, we talked about this, but we're going to talk about it again. Pain score is a subjective measure, and we're not trying to get to a 0. If we've got a patient and they're already at a 4 pre-operatively, we're probably not going to get it to a 0. We do want to increase their functionality. We ultimately want to get them back to where they can play with their grandkids, go back to work, drive a car, go to the grocery store, things that we probably take for granted because we do it every single day. Because there's so many young faces in this room, I'm going to say that. You probably think, okay, well, I get up in the morning, I brush my teeth, I wash my face, I get in my vehicle, I go wherever I'm going to go, I do my job, and then I come home. There are some people that would kill for that. And that's just something that's one way for us to be empathetic towards our patients as well. But again, our primary goal is to increase their functional status, like I said. We should be using not just medications. I mean, I'm a pharmacist. I push drugs. I do it on a daily basis. It's my job. But there are so many other things that are also effective. For example, if your patient is going to be having a total hip or a total knee, they're probably going to get physical therapy, aren't they? If we use our medications appropriately and pre-medicate them before they go to physical therapy, they'll probably do more physical therapy. They may actually have an increase in range and motion on that knee. They may be able to actually walk more than 2 steps without going, all right, stop, get me my walker, I'm just going to sit down, this hurts too much. Now, there's a fine line between making sure they're pre-medicated, but making sure that they don't fall, get dizzy, anything else. So it's walking a fine line, but it is possible. again, we need to be talking to not only our patients, but also their caregivers. So does everybody that comes in for surgery are they always taking care of their own medications when they go home? Not always. So we should not only be talking to the patients, we should also be talking to those caregivers, making sure they are aware that what they have for pain, how should it be used, what is considered okay, what's not considered okay, and when to call. So making sure that the patient's empowered with information, that's probably one of the most important things I'm going to hammer home, is that we need to provide that education to not only those patients, but to those caregivers. What's one of the things that could happen if they take an opioid and they take too much of it when they get home? They may need rescue therapy like naloxone. And that's not something that a lot of people want to talk about because, oh, well, that's only for addicts. So that's only for people that have misused their medications. I only took a couple extra doses. Taking a couple extra doses is all it needs for some people, especially if they have lung issues up front. It's something to have a conversation about, even if it's uncomfortable, because ultimately what do we want to do for our patients? We want to keep them safe. But when they go back, once they're done with surgery or once they're done with their inpatient stay, they go home and they're discharged. They have these medications. What do they need to do after that? They have to follow up. Now, many of us, if we're working on the inpatient side, we may not see that, but the primary care provider office will see that. The surgeon's office will see that. Here's something else. If you've got a patient, they're already on opioids and narcotics from another provider or pain specialist, we really need to let those people know as well. We need to make sure those patients are telling everybody in their care team. Why is that? Because eventually they're going to have to be transitioned off of those post-operative medications. A general surgeon, an orthopedic surgeon, a neurosurgeon, they're not going to keep them on high doses or moderate doses of opioids forever. Once their acute surgical pain is done, between 2 and up to 6 weeks, they're going to have them go back to their PCP. Now this is the part where there could be a disconnect, and it's important for us to recognize that we can do that. We can help by saying, make sure that when you go home, that you talk to not only your surgeon, but make sure the surgeon's office talks to your normal doctor. Make sure they talk to that specialist. The more information we can get to more people that are taking care of the patient, much more likely the patient's going to either A, listen, and B, have a positive outcome, and C, with a smooth transition. How many times have we heard patients call back and say, I have no idea what I'm supposed to do. I had narcotics. My surgeon said that I can't have any more because we're 5 weeks out, 6 weeks out, but I still hurt. What do I do? Well, the empathy in us goes, well, I need to do something. Well, what can I do? I can have them talk with their primary care, but if I set that up when they were getting ready to discharge and say, you know, do you have a primary care provider? Do you normally see a regular doctor? Do they know that you're getting this done? And just bringing up the conversation. Again, we only retain 10 to 20% of what we're told, maybe 30% if we have the videos, but when we are able to tell someone and they are able to relate back to us and show us, they retain 80%, just from an adult learning theories perspective. So, last interactive question. Pain management and the post-operative environment should be siloed and only one provider needs to know about the patient's current condition. No. Good answer. See, everyone paid attention there. You definitely get your coffee.